The requirements of the healthcare proxy are really set, so it's not the way we want, but the way it is supposed to be. So usually it will include the name of the patient, statement that the principal means the patient, interest, intent that the agent have authority to take decision for that patient, must be signed and dated by the patient, also two witnesses signed and dated. Again, yesterday we were in the medical ICU. I was with Dr. Vish trying to find a consult, to do a consult, and we were looking at the proxy, and there's so many times something missing. If something is missing, it's not dated, or you don't have the second witness, here goes your document. The document is not good. Or sometimes it's so unreadable that one wonders how we can determine who is that agent and how we can contact that agent. So I think we have to be very careful. It's not doing the document that's the big ordeal. It's to know what you put under the document and also make sure that it is done properly. Just here, mention, and the last item here, stipulating that under the healthcare proxy law, and this is something that's very important to know, you have to mention in that document what you would like to have done for artificial hydration and nutrition. So this is really an exception. If the patient doesn't write anything about that, it is assumed that we cannot stop these artificial hydration and nutrition. I'll come back on that to exemplify that. So this is the restriction. The healthcare proxy is good, but if you don't mention anything about nutrition or hydration, you will have a problem. And it has to be clear and convincing evidence that this is what the patients would have liked to be done. So either the patient will write no hydration or no artificial nutrition, or he will write a statement saying broadly that my agent know my wishes about what I want to do about that. If this is not written under that law, you will see that it's important why I'm saying that, because you will see that under the family health law, you do not have that restriction. You have it only under the proxy law. This is a proxy form that is quite standard here that we use in our hospital. So you can see it's already prepared. So again, proxy, good idea, but you need to mention something to your agent, and you certainly need to fill up the form properly. Living wills is another type of document that it's an instruction that patient, an adult, will do orally. It can be oral or in writing, and you just write or say to someone what you would like to have done in case you become incapacitated. So there's controversy about that. There's pros and cons. We can look into that. But I think it's a great thing. I will present a few examples of living wills. So it was introduced in '68, as we mentioned already. There was many efforts to publish and try to publicize, those, and try to have a better document and be more specific over time. You will see that the problem of the living wills is that it is the writing, what you put in the living will, that sometimes can be troublesome. The forms, they have forms that have been validated, and it's usually completed only by 25%. It seems that there's a big reluctance to complete the living wills. If I was to ask you here in the crowd, how many of you do have a living will? Good. You see? Probably not even 25% in this audience. So, why is that? It is that because some people do not know about that. Something they are too young, so nothing can happen to them. Therefore, it's for the old people, and we are not there yet. Reluctance to discuss that. It seems a little bit like a will. If you write it down, well, something will happen tomorrow, and therefore we are not ready to discuss that. There's a lot of incompatibility with cultural ethical belief. We know very well that there's a lot of sensitivity there, and for some people, we cannot discuss that. It's like thing will happen. The terminology, and you will see that it is probably the major problem with the living wills. It is the terminology, and I will show you how it can be confusing. the inclusion or the exclusion of what you want to put in a living will, and the transmission to the healthcare decision making. The problem with doing those documents, living will / proxy, is that sometimes we put them in a drawer somewhere nobody knows about, and therefore when we need them, we don't find them. How often we ask our family or patients to bring their document, because without those documents, sometimes we cannot make the proper decision. So the legal aspect of the living wills in New York State, there's no statute governing the living wills. They are accepted as a clear and convincing evidence of your wishes, so we take them into consideration. It's not like they are not existent. There's no standard form, and the living will can be subject to interpretation, like any document. And this is where, if we think that when we sign a legal document, it is clear and it is always subject to interpretation. This is a standard New York living will. We've seen those very, very, how can I say, very standardized. Another part of the living will. And this is a private living will here that go a little bit beyond what you wanted. As you understand, if you are too vague in your living will, well, the interpretation will be hard to get. If you are too specific, if you don't include the circumstances that you would like it to be applied, then again you will have a problem. So therefore, it's hard to get it in the middle way and be inclusive enough, but not too inclusive, therefore leaving space for the people who will decide for you what you really meant by the situation. So in this living will example, this person goes and define the terms, like the life-sustaining, what it means by that, by terminal condition, what it means by that. So therefore, it adds a little bit, it includes also that if this patient is in persistent vegetative state, fine, don't even argue, don't even go there, that's enough. And as you know, this is something that we oftentimes discuss. We don't know what to do with those patients. So in that particular living will, it was clearly said, stipulated, if I'm in this state, forget about it. Also, in that living will, there's a clause, the last one, the second paragraph. You will see that this person is added that if there's any doubt and you don't know what to do, I'm in a reversible condition, just let me go. Just don't, torture yourself and go this way or that way. Let me go. So it adds a little bit something to it. Again, that will be subject to interpretation. But to me, this is not. So I don't know what you think about this living will. Think about it. It took me about 15 years to conceive that living will. This is my living will. And that I tried to do with a lawyer, and it took me a long time to make sure that, at least at the moment, what I'm putting in that living will, this is really, I would like that to be carried out. Now the MOLS. The MOLS is an interesting document that is about 3 years old or something like that. And this is another form of determination of what the patient would like to be done in case he cannot do it. And in this case, it is different. It is the physician, in discussion with the family / the surrogate, determine what type of thing that the patient would like to be done in case he cannot determine himself at that time and decide. So this is a document of about a few pages. It's in bright pink, usually used in the nursing home, mostly not so much in the hospital. And there's an order written by a physician about all those different items that you do see that. Not only touch the DNR, but it touch no hospitalization, antibiotics, IV fluid, artificial hydration, name it. So all of those, there is a space for the physician after discussion with the patient to say, patient doesn't want that or want that. So it is an interesting document. Yesterday we spent about, again, another half hour, if not an hour, in the MECU, because we had one of those molds trying to interpret here because there were some pieces missing. The date example. This document needs to be reviewed every 60 days. And so it was not obvious to us. There was no signature on it. So again, if the document is not really appropriate, we are losing what the document was made for. It is legal in New York State, and if a patient comes from a nursing home with this document, we can respect, or we can go along with what is written in the document. So it is acceptable in the hospital as well. So this is the form. Unfortunately, it did not come out very well, but you can see the different sections that do